So, regards to what we clip, clipping for orthopaedic surgery is pretty extensive. I don't know what sort of things you guys are doing in practice, but I'm pretty sure you are aware of the margins. As a general rule, you basically clip from joint to joint around the area of which you're going to be working on 360. Everybody will have their own personal preferences, and every surgeon will have their own preference. That's what makes it really difficult to try and explain to people what's best. So we can kind of give guidelines, but what I tend to like to do is use like theatre request sheets. I don't know if you guys use theatre request sheets. So on these, basically, it allows the surgeons to communicate with the theatre staff what they actually want and what they need, so they can write their clipping margins and things on there for us. But also like a book of clipping maps. So, and it can be really straightforward. You can sort of download a picture online of just a basic outline of a dog or a cat, and then just highlight the areas that you would want clipping for, say, like a stifle surgery or an elbow surgery. It doesn't even have to be it just needs to be sort of area specific, really. So they're quite nice. Or if you've got the time and you've got the caseload, create a little picture book yourself so that then people can pick it up and look. And if you do have people that are the key members around that know everything or know all of the different surgeons' individual preferences, then at least if you've got that there, you know that, oh, Fred likes his to look like that, and Sally likes hers that way. You've kind of got that there for people, and it just helps and reduces the length of time we're doing it. So there's some guides really of where you would clip on there, but as I said, generally it's just from joint to joint circumferentially. And then the same with the foreleg. I find personally that anything sort of elbowy and shouldery, the clip does look huge. And especially sometimes if you're doing something like an arthroscopy and they've got this tiny little hole there, having to sort of, maybe the carers think, oh, why have they done that? But they're just your general things. So the next bit then is dealing with the foot. I take it, yeah, go.
Just before we move on, would you advise clipping like a day or two before surgery? If it's an inpatient,
No.
That would be a no.
No.
You've done X-rays beforehand.
No. So no clipping before. Do it all on the day. Anything that if you have caused any sort of clipper rash or clipper burn, you're just sort of, you're just giving them you're just giving any microorganisms a little bit more time to set in there. And once you're familiar and used to what you're doing, the length of time it takes, you just get quicker and quicker. So yeah, no, I
got mixed views in the practice, I thought.
Yeah, no, I never have. I understand why people would, but it's not something that I would ever have done. I mean, doesn't mean to say we have done it, as in you've had a patient and you think you're going to go ahead, and then all of a sudden it's like, no, you're like, oh, we've clipped it now. But yeah, generally I wouldn't do it intentionally. So draping out the foot, are you all familiar with draping out the feet? Yeah. So when we're sort of dealing this on our sort of side, then really it's just how we would go about doing that. So it just saves us having to clip the whole leg and the toes, because toes are a nightmare to clip. So you're just covering that limb with an impervious layer. So some different places will have different preferences. Some people like an impervious layer, so some people like a glove and then a conforming bandage over the top. Again, it all depends on your practice policy and how your surgeons work and what your surgeons like.